Okay, so my topic this morning is just to make you an update about hemodiafiltration. HDF is not really a new technology or new therapy because now already in the world it's almost 400,000 patients who are regularly treated by hemodiafiltration. So this is just showing you some practical aspect, clinical experience, and some outcome. So the first point to start is, of course, to understand that hemodiafiltration is not a generic name. The point is to achieve what we call the convective dose. That means this is part of the study that we are developing in Europe, and you see that the convective dose is reflected, or the convective volume reflecting the convective dose is the total dose that you can deliver to your patient. And you will see this is the impacting the outcome of the patient. So the hemodiafiltration should be linked to something which is a quantification based on convective dose. And the point is, of course, to achieve the convective dose, then you need to start by some practical implementation, and I will try to convince you that it's easy. So the first step is to implement hemodiafiltration. And the hemodiafiltration, you have different substitution modality. The most common in Europe is the post-dilution mode. This is the most efficient one. This is a way to save the water, to save, I would say, electrolyte. So almost 90% of the patients in Europe receive the hemodiafiltration in this mode. Now, if you move to Japan, most of the patients are receiving hemodiafiltration in pre-dilution mode. So that means Asia region is developing this hemodiafiltration for many reasons, but particularly for the vascular access limitation. So if the blood flow could be achieved, I would say 350, 400 ml a minute, it's easy to develop hemodiafiltration in post-dilution mode. If you have low blood flow, or if you are low vascular access flow, then it's a little bit more difficult for the Asian population or for the kids, for example. So just to make this I would say, to keep in mind. And of course, if you are using post-dilution, and most of the study reported would be referring to this post-dilution mode, the convective volume is something. Now, if you move to the pre-dilution, you need to consider the factors, the dilution factor too. So that means 20 liters, 25 liters post is equivalent to 40, 50 liters in pre-dilution, just to understand the ratio. So now how to move, and this is just a way to implement the hemodiafiltration. You need to target the convective volume. So you need to consider the blood flow, the anticoagulation, the filters, the machine, the treatment time, and the nursing. This is just in summary what I will show you in a minute. So the first aspect is the blood flow. And we had a fantastic presentation from the surgeon. The vascular access is very important. So you can use catheters, you can use arteriovenous fistula. I don't want to go into detail, but I will show you that the vascular access has an impact on the convective volume. Not only the way of using the vascular access, but the creation of the vascular access, but the point is how to use vascular access. And particularly if you are using fistula, it's not just because of the fistula, but the size of the needle are very important. And if you use a very small needle, 17 gauge, you cannot achieve more than 300 ml. So that means if you want to achieve 350, 400, you need to get at least 16 or 15 gauge. This is a limitation. And the same for the catheters. So that means if you are using catheters, it's not the point of the catheters. The point is to make sure that the inner lumen of the catheters is adapted to your blood flow. Just to confirm this element, this is a study with a large population showing that the mean blood flow achieved with the different vascular access, and this is in a European network from Fresenius, you see that the average with a fistula is close to 420 ml a minute. Some patients get more, so it's quite easy to achieve 400 ml a minute as a target with the fistula. If you look at this, it's a little bit more complex, and you see the average is about 300. Now, if you are using graft, it's almost close to the fistula. So just the vascular access has some impact on the flow that you can achieve. And again, if you link this vascular access to the convective volume, and if you state that the substitution volume targeted is 21 liters, referring to the first slide, 23 liters, because it considers ultrafiltration for the weight loss 21, 23, this is the same. You see fistula graft in almost 90%, you can achieve the target easily. Now, if you are using catheters, it's a little bit more complex. Second aspect is the anticoagulation. Yesterday, I discussed with some of your colleagues, and I know that you are using the unfractionated heparin. So no way it's unfractionated heparin that works anyway. But still, if in some patients you are using the fractionated, the low molecular weight heparin, the site where you inject the fractionated heparin is very important. Why? And you will see in a minute. If you inject the heparin in the arterial way, you can lose almost 20 or 30% within the first passage of the filters, because the molecular weight of the or low molecular weight heparin are around 6,000 Dalton, and then that means you are losing a lot within the filtration. So that means the main recommendation is to inject all the anticoagulation not on the arterial side, but on the venous side, and preferable either on a bubble trap or directly to the patient. Then you create a systemic anticoagulation, antithrombotic activity, and you are at this point sure that you are not losing, I would say, anticoagulation within the filter. And that was done in a study in France. I don't want to go into detail, but just to show that with low molecular weight heparin, in that case, nadroparin, which is 6,000 Dalton, the study was very simple. Phase 1, phase 2, phase 3. The idea was to inject first, as mentioned on the leaflet of the nadroparin, to inject in the arterial side. So the first step was to inject the arterial side with a certain dosage. The second step was to inject in a venous site. And the third step was to inject in a venous site by reducing 50% of the dose. And this is just a clear indication what's happened on the fetus. And then just by changing from arterial to the venous side, you can reduce almost 50% the thrombosis event. So it's easy, nothing to do with a complex system, but this is affecting, I would say, the thrombosis and the coagulation of the filter. So the third element is the filter. Now you are using capillary or hollow fibers, and within all the hollow fibers and high flux hollow fibers, you have what we call internal filtration phenomenon. And this is linked to this transmembrane pressure. You see that if you look on from the arterial side to the venous side, this is a blood pressure drop within the filters. This is on the opposite, the dialysis. Then you have two zones. One, the first is a positive ultrafiltration. The second one is a back filtration. So that's almost all the filters provide such, I would say, internal filtration. But now, from the manufacturing process, a lot of dialyzer manufacturers try to increase this phenomenon by reducing the inner lumen of the fibers to increase the resistance. So that means you increase tremendously this phenomenon. Now, if you use the filters, which is designed to increase the convective volume in regular hemodialysis, but if you want to use this filter in hemodiafiltration, then you don't increase the efficiency, you are losing efficiency, since at the end of the dialyzer you get, I would say, tremendous, I would say, clogging, fouling of the membrane, and certainly hemoconcentration. So at the end, you need to find the right filter. And the right filter for hemodiafiltration is very simple. It's, of course, high flux membrane, but with the diameters of the inner lumen diameter, which is over 200 micrometers. So if you just check on the eye view, you will see that some filters get, I would say, 180. This is not fitting with hemodiafiltration. You need to get something which is higher, just to make sure that there is a low internal blood flow resistance. And also the safety. Sieving coefficient for the albumin should be very low. You don't want to lose albumin. And also the sieving coefficient I showed yesterday for the beta-2M is over 0.6, but this is in all generations. Now the new filters is over 0.9 and even sometimes 1. So this is something you have to keep in mind to get the right hemodiafilters. Now, if you get the right hemodiafilters, then depending on the surface area, and this is from the lowest to the highest, you see that if you use high blood flow, and this is over 350 up to almost 400, then you can achieve a convective volume which is over the 23 liters, 25, 27, up to 37. So that means if the patient needs, for the metabolic needs of the patient, need to increase the efficiency, then you have to increase the surface area, you have to increase the blood flow, and then you can increase tremendously the efficiency of your system. The last point, not the last, but this is a machine, because the filters is something. And the online hemodiafiltration, as you know, this is a way to substitute what you are removing by ultrafiltration by the machine. And this is a new generation of machine that you have seen, the 5008, just to give the name. This is a sort of smart, intelligent hemodiafiltration. Why? Because the machine is sensing some change within the filter. So that means any change from the viscosity inside the filter is sensed by the machine, and the machine adjusts automatically the filtration fraction. So that means you don't have to care, but if you set the functionality to say auto substitution, auto flow system, so everything is, and the system will take care of adjusting the ultrafiltration control. So you have a permanent automated ultrafiltration control in the machine. So you don't have to make manual prescription. The machine will manage to achieve the highest convective volume. And this is coming back to the slide I show you. This is a way to achieve the maximum of the ultrafiltration. And just by using the auto sub plus functionality, which is a way of controlling the ultrafiltration, you can increase by 4 to 5 liters each session without to make any change. The point is, of course, time. And hemodiafiltration is not to reduce treatment time. So this is a mistake that sometimes the physician want to do. If you increase the efficiency, you think that you can reduce treatment time. It's completely wrong. I will show you in a minute. Treatment time is very important, and yesterday we talked about the 3, 4, 5 hours, I don't care, the frequency. The treatment time is very important for the clinical tolerance for the ultrafiltration. You can reduce the ultrafiltration, you can improve tremendously the hemodynamic stability, the patient perception, but also you can increase tremendously the removal of substances. I will show you in a minute. So don't reduce treatment time. And this is just an illustration. And you know that beta-2M is a fantastic marker. I'm really fan of the beta-2M. This is a prospective study just comparing the hemodialysis, high flux 4 hours, to hemodiafiltration 4 hours, then hemodialysis 8 hours, and hemodiafiltration 8 hours. So you move from 4 hours hemodialysis or hemodiafiltration to 8 hours in hemodiafiltration. And this is a total mass of beta-2M removed. So it's not a reduction rate. This is what you collect in a dialysate. Then you move from 100 milligrams in 4 hours hemodialysis to almost 150. Then hemodialysis 8 hours is almost equivalent to 4 hours hemodiafiltration. Now, if you increase to 8 hours, it's close to 200. So that means from 100 milligrams, you can move to 200 milligrams just by increasing the treatment time. So just keep in mind that treatment time is very important for the solute removal. And the last point, nothing can work if you don't have the right nursing team. And I'm sure you have nurses here. If you are not motivated, if you are not committed, if you are not trained, if you don't have the skill team, the convection will not work. So that means convection should be performed with a tremendous conviction. Okay? I will show you in a minute why. And this is part of the explanation of the, I would say, pure finding of the contrast study. You remember the contrast study was the first randomized study with hemodiafiltration conducted in Netherlands. And at the end, the primary outcome was not achieved. So there was no differences in terms of mortality between hemodialysis and hemodiafiltration. So you can say from evidence-based, it doesn't work. But the point, if you go inside the study, you will understand why. Clinical practices, and yesterday I talked about the clinical practices. 26 or 29 centers were participating in the study. And the target in the protocol for the randomization was to achieve 6 liters, not per session, but per hour. So that means 24 liters per session. Look how many centers, and this is average of the convective volume achieved by the dialysis center. Only 1/3 or 1/4 of the center were in the target. So that means you make a randomized study with a target which is very clear, and 2/3 of the center were out of the target. So how you can consider the randomized study as some information is completely uninformative. And the point, of course, if you just look in the same centers, on the left side, you get the convective volume, and on the right side, you get the blood flow. And you understand immediately why the center were achieving the convective volume, where the center who were able to develop 400 ml as a blood flow. If you just stay less than 300, it's almost impossible to achieve the convective volume. So very simple practices improve, I would say, the result, the intermediary outcome. So what is the clinical experience? And the clinical experience, I will just summarize. We have different views, and that was already mentioned. The clinical experience differs from the stakeholder perspective. As a patient, you want to improve your perception, to reduce mobility, and so on and so on. From the nursing, you don't want to get, I would say, you want to get a very use functionality, you want to save time, you don't have to reduce the care burden, so just to optimize the workflow. Now, if from the nephrologist, of course, you want to increase performances, you want to reduce intradialytic mobility, but you want to improve long-term outcome. From the healthcare system, you want to reduce the cost. So different perspective. Now, what we learn from this study, and I will try to summarize. One is the biological and clinical effect. Of course, we can look on different markers, solute removal, but clearly the hemodiafetation is not to increase the KT over V. The hemodiafetation is to improve something which is a little bit different, and particularly middle molecule or different, I would say, molecule. Improve the hemodynamic stability, reduce what kills the patient, the inflammation, the anemia, and malnutrition. So this is what I will show you in a minute. The first aspect, which is with the hemodiafetation, and certainly was one of the first findings, hemodiafetation reduces the prevalence or the incidence of intradialytic hypotension. I just put different studies showing that at the end, very simple parameters, numbers of intradialytic hypotension are reduced significantly by hemodiafetation. Different elements can explain this element, could be the hypothermic condition, could be the sterility, could be the removal of substances. I don't want to go into detail, but still, this is true. And even in the elderly patient, and elderly, this is a French study, mean age was 75. They reduced cramps, reduced some, I would say, nausea, vomiting. So at the end, even in the very fragile population, there are some beneficial effects. Now, if we move on, I would say, solute removal. I don't want to go into detail of all these elements. I selected 3 markers, urea, because you are using every day, phosphate, and beta-2M. If you see what we do with hemodiafetation, and that was all studied 20 years old, but that was made with a urea monitoring system. So this is a urea monitoring system collecting the diazide. And already in almost 2000, you see that the KT over V, which is a double pool KT over V, was already 1.5, 1.6, 1.7. So it was already very high. And PCR was, I would say, very correct, the solute mass removal. So already 20 years ago, we know that hemodiafetation was doing much, I would say, was delivering much more efficient treatment as compared to the regular hemodialysis. Not only. Now, focusing on the beta-2M, and this is a systematic review or meta-analysis, if you want, comparing, I would say, all the study reported with the hemodiafetation on the beta-2M. So if you look these clearances, and this is a clearance for the high flux hemodialyzer, so the average for all the study is about 50 ml a minute, if you just use the same filter in hemodifiltration, you multiply by 2. So the increase is almost 80% just by switching to hemodifiltration. This is confirmed by the, I would say, contrast study, even with the, I would say, biases of the study. Just look on the beta-2M. The beta-2M is almost 25, 27 milligrams as compared to the hemodialysis, which is close to 40 milligrams per liter. So we can reduce. And yesterday I showed this slide, and remember the beta-2M, the relative risk of mortality, the threshold is around 23 milligrams per liter. So over, you have a tremendous risk of high mortality. Phosphate, and this is also based on the, I would say, randomized study with a quantification. Just for the comparison, again, very old study, more than 15 years. Comparing high flux hemodialysis to hemodifiltration, there is an increase of reduction rate, but much more interestingly is on the phosphate mass removal. You almost increase by 20%. Just the same time, the same technique, and the same patient. And again, that was confirmed in the French study, just showing the pre-dialysis phosphate level as compared to hemodialysis, and the percent reduction and the phosphate level. So just confirming that you can keep this same, I would say, efficiency over the time. Now, if we forget the elderly patient, but you move on the other side, the kids, and this is coming from the study, 3H study, which is a UK, Turkish, and different European center, showing that in the kids, so very young population, within 3 months, when you switch the kids from hemodialysis to hemodifiltration, look what's happened on the beta-2M, so you can reduce almost by 30%. Look on the inflammation marker CRP, you reduce. So that means even in the kids, which are not so fragile, you improve tremendously the efficiency, but also you reduce inflammation marker and you reduce endothelial dysfunction, ADMA, DMA, just showing that switching this population in hemodifiltration improve a lot of markers. Erythropoietin resistance index, and that could be interesting for you. If you want to reduce the cost of anemia, and this is coming from Italy, this is the REDIRT study, showing that within 3 months you can reduce erythropoietin resistance index. So that means you keep the hemoglobin level and you reduce the consumption of EPO. That's just confirming the beneficial effect of this element. And that was also shown in the in an incident population, a large population. This is erythropoietin resistance index in hemodialysis patient and in hemodifiltration. So within few months and almost 2-3 months after the start of the hemodialysis, you see that there is a discrepancy between hemodialysis and hemodifiltration. So reducing the erythropoietin resistance index is something we know. Again, and the last point, nutritional aspect. And this is also from Spain. This is a prospective study, randomized, comparing, I would say, body composition change in a patient receiving hemodialysis and versus hemodifiltration. So this is lean tissue mass or muscle mass, fat mass. What you see is hemodifiltration, they are very stable for the tissue, for the fat mass. Why, if you compare to hemodialysis patients, they are losing, I would say, almost 5% of the lean tissue mass, and again, fat mass within 1 year. So there is some beneficial effect also on the nutritional aspect. Outcome, and I will be short on this element, I selected mortality and patient perception and some healthcare economy. I show you this slide. I did not mention on the top of the slide all-cause mortality. This is a risk ratio according to the convective volume. What you see on all-cause mortality and cardiovascular mortality, more you increase the convective volume and more you have beneficial effect on the patient. And this is part of the study that was performed in Europe. So this is a European pooling project. So all the 4 randomized studies were collected, and this is a reanalysis with an individual patient data analysis, so it's not just meta-analysis, showing that in In this group, we had already 2,700 patients, followed for more than, I would say, 3 years. All-cause mortality is reduced by 14%. Cardiovascular mortality is reduced by 23%. So this is sort of, I would say, confirmation that the beneficial effect is on all-cause and cardiovascular. But more interestingly, this is where we get this convective target, which is 23 liters. You need to provide, at least in this population, 23 liters to get, I would say, all-cause cardiovascular and to get some beneficial effect, which are summarized on the right side of the slide. And the beneficial effect is not just on all-cause. This is related to cardiovascular origin. As shown on this slide, there is no significant effect on the infection or different, I would say, all-cause mortality, but this is to reduce myocardial infarction, arrhythmia, and congestive heart failure, as shown on this analysis. So the beneficial effect is really focusing on the cardiac system. Patient perception, this is a fatigue. Again, this is a meta-analysis showing that the fatigue tends to be reduced in hemodiafiltration. That's something we are looking after. Time of recovery, there was no differences as compared. This is a randomized study performed in UK. Recovery time was almost equivalent, so 2 hours as compared to high flux hemodialysis. Now, if you look on the patient, recovery time, immediately after the dialysation, 30% in hemodialysis, 34% in hemodiafiltration. So no significant differences in average, but some patients take a little bit more benefit from the hemodiafiltration. And the last element, which is from Brazil, this is as they fit. The idea was to compare the hemodiafiltration and the high flux hemodialysis in a relatively young population to see the impact on the physical activity. And what they show, unfortunately, was not sufficiently long, 6 months, and the physical activity was quantified by the number of steps per day. There is a beneficial effect on the hemodiafiltration. Unfortunately, the significance was not achieved after 6 months, but still, as compared to hemodialysis patients. So maybe some anthropometric benefits were coming from this physical activity. And the last point is a healthcare perspective. That was conducted in a contrast study, the Canadian arm, showing that at the end, for the Canadian setting, healthcare system, the hemodiafiltration could be considered as cost efficient, and considering that the beneficial effect on the life, quality of life, quality adjusted life you heard yesterday, considering that the increase for the quality was 32,000 or 53,000 Canadian dollar, which is accepted in your system. Just to end this element, and you understand that the hemodiafiltration brings something new for the patient, and this is analysis that we perform with a group of experts. The putative mechanism, how to explain that hemodiafiltration is beneficial on the cardiovascular system, we put what we consider direct factors such as hemodynamic stability, cardiac remodeling, inflammation, oxidative stress, endothelial dysfunction. This is clearly something we observe, and certainly some indirect factors such as the anemia correction, nutritional status, physical activity. So this is all these factors who can explain why the hemodiafiltration acts differently on the patient. And then the last message, hemodiafiltration is currently the most advanced and effective, I would say, in-center modality associated with a lot of advantage. Easy to use, as I show you, easy to implement. It enhances the treatment efficacy and the tolerance, expands the solute removal mass to larger molecular weight substances, not to increase the KTOV, reduce inflammation, oxidative stress, improve the endothelial dysfunction, facilitate the anemia, preserve the nutritional status of the patient, reduce treatment burden for patient and caregivers, and reduce mortality on all-cause cardiovascular, and must be considered as a cost-effective treatment today based on the healthcare systems that we have. Thank you very much for your kind attention.